Professor. Hello, Professor.
Yes.
Yes.
The dean is getting ready right now. May we wait like a couple minutes, a moment, because it's already.
Yeah, it's okay.
Okay.
哎，世君，他怎么？哎，世君，your background, you have to shift to the mirror, no mirror rejection. 没有影像。
近摄吗？近摄有什么用？
近摄。
有，哎，可是我看起来是近摄的。
哎，对，那我的呢？那我是不是？
那你的
我们看起来是
你的我们看起来是正的啊，世君的是反的。啊，我的呢？
哦，我的也是正的吗？好。
对，啊，你看我的是正的还是反的？
对，老师你是正的。
那现在世君你的是反的。
哎，可是我的荧幕看起来是正的。
哎，可是没有，世君你看起来是反的。
是我们看起来
看起来是反的。
哦，好，那我再试一次。
好像再去给它转一下。
好。
那个启林刚他说那个前面 introduction 好像不会到那么久，所以我们可能会提前15分开始。所以你也会就是你也会，我们也是还是让那个时间给你。
OK， 好，那老师您觉得我的声音够清楚吗？
有很清楚。
哦，很清楚。好，很清楚，很清楚。
那个
老师，如果我在4楼，如果不清楚，我就要到会议室去。那如果清楚，
会议室其实要用麦克风，其实也没有比较好。
哦 ，OK， 好。
那个是现在这样我有亮吗？因为我已经跑去找弄了一个
OK 可以啊，老师很 OK，
有亮了 OK。好，
世君在设那个背景的时候，要把那个镜像影像镜像要把它勾掉，要不然它会变成倒反的。
没有，因为我本来就把图案弄过去，这样子可以吗？
还是一样，
现在还是反的，就是你在设定你的那个背景的时候，那边有一个镜像，那边你把它勾掉。
哦，哇，好，再一次。这样子呢？
这样 OK 了。
OK， 好，谢谢。
世君，你把那个麦克风关掉，我试试看，因为你现在一直在我画面上面。
哦。
Iya, saya masuk ya.
Hello.
Can you guys hear me? Is my voice clear?
Yes.
Okay. We will begin. Okay. Ladies and gentlemen, may I have your attention, please? Our event is about to begin. Please have a nice seat and thank you. And for the students, please turn on your camera, and if possible, please put the background for this meeting. And I apologize because I cannot use the background, so it is my background. Okay, the dean is here, and also the professors are also here. I will begin. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
warahmatullahi wabarakatuh.
Good morning, ladies and gentlemen. Welcome to the first international joint class between Master of Nursing Program of Faculty of Nursing Universitas Muhammadiyah Jakarta and Nursing Department of National Chengkung University. It's a great honor for me, Ibrahim Kamil, to be the Master of Ceremony for today's event. Ladies and gentlemen, over the next approximately 4 hours, this meeting will provide you with knowledge, especially in palliative care. Before we proceed to the program today, we would like to express our sincere gratitude to our Honorable Dean of Faculty of Nursing Universitas Muhammadiyah Jakarta, Mrs. Michu Umeda, and also the Honorable Head of Program of Master of Nursing Program, Dr. Nima Seni, and also the Honorable our guest lecturers for today from National Chengkung University, Professor Huang, Michu, and also Professor Cao Chi-yin, the Honorable lecturers from Faculty of Nursing Universitas Muhammadiyah Jakarta, and also our beloved student from Master and Specialist Program. Without further ado, let's welcome our Dean, Mrs. Michu Umeda, who will deliver an opening speech for today's event. Mrs. Michu Umeda, the time's yours.
Baik, sudah terdengar suara saya, Mas Kamil?
Ya, Bu.
Sudah Bu.
Ya, bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Ladies and gentlemen, good morning, Profesor Huang Michi, Profesor Cao Chi-yin. Terima kasih sudah meluangkan waktunya. Pertama-tama, marilah kita panjatkan puji dan syukur kehadirat Allah Subhanahu wa Ta'ala. Salawat dan salam kita sampaikan ke junjungan kita Nabi Muhammad SAW, yang mana pada pagi hari ini kita masih diberi nikmat sehat, nikmat iman, sehingga kita bisa melakukan kegiatan join class dengan NCKU, ya. Pada kesempatan hari ini saya sampaikan yang terhormat para pimpinan di lingkungan Fakultas Ilmu Keperawatan, yang terutama yang kami hormati adalah Profesor Huang Michi dan Profesor Cao Chi-yin yang telah meluangkan waktu pada pagi hari ini untuk bersama-sama kami dalam kegiatan Joint Class Internasional yang diselenggarakan secara kontinu dan konsisten setiap tahun akademi dalam rangka untuk meningkatkan wawasan pada mahasiswa kami, terutama adalah mahasiswa magister keperawatan dari berbagai peminatan, yaitu peminatan medikal bedah, peminatan keperawatan dan manajemen keperawatan, keperawatan anak, keperawatan komunitas. Sehingga wawasan ini nantinya diharapkan bisa memberikan peningkatan pengetahuan dan keterampilan dalam memberikan keperawatan, khususnya adalah perawatan palliative care di tatanan klinik maupun di tatanan komunitas. Pada kesempatan hari ini juga kami sangat berbangga karena kegiatan ini kita bisa laksanakan walaupun dalam kondisi pandemik kita tetap bisa bersilaturahmi untuk melaksanakan joint class internasional ini. Insya Allah ke depan setelah selesai kondisi pandemik COVID ini, baik itu yang terjadi di Indonesia maupun di negara-negara lain, kami berharap kami dapat berkunjung langsung bersama dengan mahasiswa kami ke NCKU untuk kuliah bersama, saling bertukar informasi, dan melihat secara langsung kegiatan pembelajaran yang dilaksanakan oleh NCKU. Kegiatan internasional joint class ini dilaksanakan secara terus-menerus sehingga kegiatan ini nantinya akan berkembang baik ke depannya, dan kegiatan kerjasama ini juga kami mengharapkan tidak dengan NCKU saja, tetapi juga dengan negara-negara yang lain. Kami mengharapkan mahasiswa dapat memiliki wawasan keilmuan yang lebih, yang terus dapat berkomunikasi baik itu dalam mengembangkan ilmu keperawatan di Indonesia maupun ilmu keperawatan yang ada di negara-negara yang saat ini sedang berkembang. Sehingga mereka atau mahasiswa kami dapat menjalin persahabatan yang lebih baik lagi dengan luar negeri. Dan akhir kata kami sampaikan kepada Profesor Huang Michi dan Profesor Hua Michin untuk memberikan informasi, wawasan khususnya terkait dengan perawatan paliatif yang ada di negara Bapak, Ibu-ibu, dan tentunya informasi ini menjadi hal yang sangat baik untuk wawasan mahasiswa kami. Mungkin itu saja yang bisa kami sampaikan. Lebih kurangnya mohon maaf. Dan pada kesempatan hari ini sekalian saya buka untuk acara Joint Class Internasional ini dengan NCKU dengan sama-sama melafazkan basmalah. Bismillahirrahmanirrahim. Dan akhir kata saya sampaikan pesan kepada seluruh mahasiswa agar dapat mengikuti kegiatan Joint Class Internasional ini dengan baik dan penuh perhatian. Terima kasih. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, I will summarize what our Dean just speak. Our Dean expressed her gratitude for today's speaker, Professor Huang, and also Professor Cao. She hopes that students will gain many knowledge from the professor, especially in the palliative care nursing. She also wished that when the pandemic is over, we would like to visit NCKU and see directly how is nursing over there. Our Dean hopes that this kind of activity will be continued over the years, not only with NCKU, but also other universities as well. Again, thank you very much for the professor for the time and the opportunity that you gave us today. And she also remind the students to be proactive in today's event, because this is a rare chance that you get direct knowledge from the expert, especially in palliative care. And don't forget to submit your assignments tomorrow. Okay, without further ado, let's move to the next agenda. The first agenda is the lecture from Professor Huang Michu about palliative care for terminal ill patients in children and adults. And for the lectures, our activity will be guided by our staff, our lecturers, Miss Dea Natasha, PhD. She is our lecturers as well, who just finished her doctoral study in NCKU. and became our youngest PhD in Faculty of Nursing, Universitas Muhammadiyah Jakarta. She has many publications, especially in medical surgical nursing, and hopefully she will join us soon, yeah, after all her study finish. Maybe a couple months from now, she will join us and teach us in our faculty. So so please welcome Mrs. Dea Natastia, PhD. The time is yours.
Okay, thank you, Kamil, for your kind introductions. Good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. I'm Dea Natasha, as the moderators today for the lecture sessions of International Joint Class Program in collaborations between University of Muhammadiyah Jakarta and National Chengkeng University. So I'm very pleased to see you here and welcome all of you to following our two session of lectures. So we have the two topic from two outstanding professor, and for each sessions we have 70 minutes for the lecture and continue by the discussions for about 20 minutes. So I will give an opportunity for all of you to ask the direct questions and also open the chat room. If you have any questions, you can try to write there and I will read for you if we still have a time in the discussion sessions. So next slide, please. And next slide. Okay, let me first introduce our first speakers. We are very honored to have the first speaker, Professor Huang Michu. Currently, she is a professor at Department of Nursing, National Chengkung University, and also as the president of National Taiwan Junior High School. Her clinical research specializations include pediatric nursing, palliative care, and end-of-life care, bioethic, research integrity, transcultural nursing, and also genetic nursing. She served as a standing director, Stigma Theta Tau International, the Honor Society of Nursing, and as a leader in the Taiwan Associations of Nursing Educations. She have a long list of publications and research grants, both national and international level. And I just list the most recent publications of palliative care that just published in 2020 at Journal of Palliative and Supportive Care and also Australian Journal of Primary Health. So we are very lucky to have her today as our speaker. So without any further ado, please join me in welcoming our first speaker, Professor Huang. Professor Huang, time is yours.
Okay, thank you for the Dean's remark, and I also feel very honored and very happy to be invited to be a speaker here. And also thank you for Camille's introduction and Diaz. And congratulations for Diaz, you are get your new academic career in your new life. Congratulations. And I will share the screening first. Let me please wait a moment. Can you see that?
Yes.
Is correct? Okay. Okay, thank you. And for today's talk, today I get the topic is a palliative care for terminal ill patient, and we were talking about the children and adults. And today's talk, I would like to invite. This is me. This is me, and the research focus recently is on pediatric palliative care, transcultural education, nursing education, and bioethics. And I would like to invite one of my PhD students, and actually Lin Sijun. Sijun actually now she is a candidate of PhD students. And I would like, please, Sijun, could you introduce yourself?
Yes, my name is Jun, and I am now a researcher, a PhD student, and an assistant in NCKU and Department of Nursing. I have an experience in joining the UK and Taiwan Innovative Industries Researcher Placement Program and received the Palliative Care Research and Outcome Measurement Training at Cicely Saunders Institute, King's College London in 2019. My research focused on epidemiology, palliative care services, and children and family with life-limiting conditions.
Okay, thank you for Sijun's introductions. And so for today's talk, we will share for some introduction because I want Sijun currently, she is focused on the pediatric palliative care study. So we would like to share together and then hope everybody can accept for this way. And now I will start to say, according to WHO 2020, it's about 40 million people are in need of palliative care, but 78 of them is in the low and middle income countries. So now only about 14% of people who need palliative care currently is really receiving it. So it means the palliative care for us, that is a very I think this is a kind of things we have to understand that and to try to provide as a health profession. We try to provide to support our people. And historically, as our understanding of the palliative care, they are usually start for the diagnosis and going to the death, and it's kind of mutual exclusive to active and aggressive treatment and the palliative care. So sometimes we think about that like a cut, and say if the going to the palliative care, it means it's no active treatment. And we all know the if you go into the Google to search, then you will find many pictures. They are talking about the palliative care, and we'll see the transitions of the palliative care would be. The old concept is just like we say, the curative care and the palliative care is mutual exclusive. And it's kind of when you have a cut, now you will have a curative care. But if the curative care is impossible to get the patient cured, then we shift to the palliative care. That's an old concept. But this concept is also I think many our people, our patients, they are think about that. And the better concept of the palliative care, we have another way to have a line and to separate the rectangle to the disease modifier or potential curative, and also with the supportive and palliative care together. So it means when we get the diagnosis or we get one disease and start from the treatment, then the sort of the palliative care also join that. And then if the curative looks more impossible, then we shift more part for the palliative care. And also another triangle is after death, we also need to do the bereavement care. So that is a better concept for that. But for this, they all things. When we're talking about palliative, it looks you are going. The end point is death. So now but we know the disease, the trajectory of the dying is not the same. That's the same. So we have the different type of dying, like sudden death. There's some accident that could be like a sudden death. And if for the terminal illness, there will be we maintain a good function, but then will decrease in a very short time. And for some part like the organ failure, that we can the function level would move down and up, down and up, down and up, and then maybe spend a longer time and going to death. And if for that the elderly process, natural elderly process, or some fragile like dementia, then you will see the period is longer, and then it is slowed down. Yeah. So you will see for a different condition or different disease, we do have a different trajectory of dying. So it is not mean when we got some diagnosis or we got some life-threatening disease, that would be the same way to go into the dying. So because that's different, so we have to think about the different way to think that. Okay, then I should please Sijun to say something about this.
As Professor Huang just said, because palliative care is a term that related to death or dying, therefore, patients often said, "This is not for me," and they are reluctant to be referred to palliative care. So they are not referred to palliative care. They're not knowing there are resources exist that who can helping them in the end of life or during the illness. Oh, and the next page from the parents of children who are dying or who have the palliative care need. Parents said, "The doctor told us to give up on our child." So palliative care linked to give up, and it is also causing the poor family professional relationships and the caregiver having high burden and suffering. And the next page, from the physicians or other healthcare providers, they often said the patient is not at the level yet, meaning it's not at the level of palliative care yet. They setting restrictive palliative care service eligibility criteria. And for a patient with chronic critical illness, often stuck in ICUs and cannot receive a better care in the ward or at their home. And this also caused a high cost due to providing high intensity end-of-life care.
According to the WHO definition, we would like to say the palliative care we definite as a multidisciplinary approach that improve the quality of life for patients with life-threatening illness. So it will be through the prevention and relief of the suffering by the early identification and assessment and treatment of pain and other physical, psychosocial, and spiritual problems. So it means the palliative care is the comprehensive way. It's not only for some part. So we would like to say the palliative care is most valuable when integrated earlier in the course of illness. And I would like to say, based on some evidence base, we will see if we earlier should do the palliative care integration, then the effect we will see they can increase the family members to the hospice involvement, and would be decrease the family's anxiety and improving their coping skills. Also improve their communication among the family members, and also improve the family relationships. And if we delay the palliative care integrations, and about the symptoms, quality of life, care preference will be less addressed. So actually, we don't have the enough time to do this. And also the family, they also inadequately to being prepared for their loved ones' death. So the time is too short, and the situation changed too fast. So that's why we are talking about the earlier integration is good. But and also from our study, that also the part of the Sijin's study, and what is the trigger leading to palliative care discussions? And because of especially for the children's palliative care, we always feel very hard to start to talking about the palliative care. And but when we interview our healthcare professionals, and when they think they need to start a palliative care discussion, when they think they have to share the knowledge regarding which is for care, and especially among their healthcare teams and also the family members, and also they think they have to do the end of life decision making with the family members. So that would trigger the healthcare professionals who want to start to leading the palliative care discussion. But they also, when they want to do that, they also have very strong consideration about actually sometimes it is fair to predict the timing. We don't know what is the right time. And also they also concern, does the family member have the motivations for palliative care? And as a healthcare providers, we are very worried about if we start to do the discussion the palliative care, and they will causing the harm for the relationship between the patient and the family members, the patient and the professionals relationship. So that is our result from our study. So the barrier to integration palliative care would be family. The barriers, the difficulty with accepting poor prognosis. The family is very difficult to know that, and also with understanding the limitations of treatment. So even the healthcare professional also very difficult to say the treatment has a limitation, and the lack of agreement about the goals of care among the family members. And also the social exclusion of the family, and actually in Taiwan, and I think in the Asian environment, talking about the death is a taboo. It is very hard to say that. So, and the lack of the clarity regarding the nature of palliative care. So that is the barrier for to talk about the palliative care with family. So there may never be a good time to talk about palliative care, but also actually the time is always right to do what is right. And so now we would like to talking about the new models of the integrated palliative care. We call that bow tie, and you will see the bow tie model. They put the disease management and palliative care as a two triangle, and they work together. So it means this. So we call that integrated palliative care. So for the disease management, of course, that is more focused on the many disease treatments like chemotherapy, radiotherapy, transfusion, and the anti-nausea drug, something like that. So we would do a lot of treatment for treatment of disease. And so the disease management will focus on the care and the control the symptoms. But for the palliative care part, the major part will be the symptom management and also to provide a time and the opportunity to let the patient to stay their advanced care planning on the ACP. So when we start to the palliative care, it's not mean everybody will go to death, but it also has the possibility to go into the survivorship. So if the outcome is the patient or the child is still in the survivorship, and the rehabilitation will be part of our care. And if the endpoint is going to the end of life care, then have a more palliative care and using the hospice. And after that, using the bereavement would be another choice. So this bow tie model give us the new concept and the new way and to talking about palliative care. Not only for the healthcare professionals to change the thought, also that the family members or our people also change the thought about palliative care. So the integration of the palliative care with disease management would improve the quality of life and symptom control, and also improve the quality of life for the caregivers. And we also can facilitate the patient or the family members that to do the early advanced care planning, and also will be facilitate they withdraw a ventilator support outside the ICU setting, and more choice to choosing the place of death is outside of hospital. Actually, for our people we also have a very strong motivation to die at home, then there would be also another effect for that. And the integration of palliative care with disease management also can reduce the risk of appropriate interventions. Like for some patients, actually the ICU administrations may not be the best choice. And so, and also for some disease like the cancer patient, and if the chemotherapy is continuous to the last day of life, and it's also not a good way for that. So this model also reduce the cost to healthcare systems, and then we can reduce the ER administration, reduce the acute bed stay, also reduce the many doctor visits. So for another publication to see, this is a SR systemic review paper, and we review the impact of palliative care on end-of-life care. Well, the finding, see, the result is decrease the ICU administrations, and decrease the high intensity end-of-life care, and less likely to die in ICU. So from this systemic review, we'll see palliative care actually have their very good effectives, but we need to make more positive concept about the palliative care. Now we shift to Sujin.
Okay, and palliative care includes a multidimensional care. And first of all, I'm saying the first important one is the symptom care. In cancer patients, actually they have numbers of distress symptoms. The first highly prevalent is the weakness, fatigue, and pain. And the next one, for the end-of-life symptoms, the most common is pain, dyspnea, fatigue, seizures, and drowsiness, sore mouth, skin problems that we have to address. And there's a concept of total pain, that pain is the most important not only in adults but also in children. And pain interfere the quality of life and comfort, and it worsens the somatic and the psychological status of the patient. The concept total pain, meaning that this is a very complex nature, that pain will impact and causing from physical, psychological, social, and spiritual dimensions. The experience of pain is also very unique. So we have to trust our patient that they say they are painful, it means they are pain. But why the pain management is so important? Many people think that pain cannot be managed and have to be in that way during end of life or when you have a seriously illness. But pain will impact a patient's fatigue, poor sleep, less active, and cause less time with friends, depression, and causing more stress and less self-confidence and more anxiety. And you can see this page of the pictures. The patient is lying at the bed and he cannot move, and he has stiffness in his hands and legs. So it's causing all the problems from the left side. And the next one, first of all, we have to manage the pain. We have to use pharmacological approach. That is the first step. And from the WHO's recommendations, there are some principles that we can follow, very simple principles, like by mouth. So whenever possible, you first think about the oral routes of analgesics should be given by mouth. And second is by the clock. So regular scheduling ensures a steady blood concentration is important. you should not give the analgesics when they say they are pain. That it will be too late for pain management, and that will affect their quality of life. And the third is by the appropriate route. So we use the least invasive route of administration. And we have to follow the guideline. And a 3-step analgesic ladder is widely being used in cancer care by the WHO in 1986. It said that the first step is using the non-steroid anti-inflammatory drugs, NSAIDs. So the NSAIDs include drugs like ibuprofen or acetaminophen. Thus, if the pain is getting worse or not controlled, then your healthcare providers can prescribe the weak opioid medicines like hydrocodone or weak opioid combined with non-opioid pain reliever. And the third is if the pain is getting worse, you can think about stronger opioid like morphine and fentanyl. And adjuvants from the you can left down. There's the adjuvants include antidepressants, anticonvulsants, antispasmodic, etc. These can combine with the opioids or the medications. However, in the guideline from WHO in 2018, they think about maybe better ladder is not really useful for the clinical setting. So they more emphasize on for the individual. So we have to, when we choose the medication, we may think to adapt the treatment to the individual, what their side effects, how's their outcomes, how's their pain control outcomes. We first think about, we do the pain assessments. That is more important, and we have to do that first. And with attention to details like the patient routine, where their day and night routine, their regimen have to be clear, medication, the name, the routes, and the dose, and with their adverse effects, should be paying more details attention. And the next, about non-pharmaceutical intervention, there are numbers of ways. First of all, for pain management is the physical comfort. For the preterm infants or babies, we can use kangaroo care, that putting them on the mother or father's chest and to make them calm and make their decrease their distress symptoms. We also can use bed bath. These are the photos from NCKU hospital hospice ward, that we have a bathtub in the ward that could give the patient bath bath. And a heat and cold pad can also helpful for or for abdominal pain. And washing hair on the bed is also helping them to have clean and have very sense of relief when they are in the illness. Positioning for comfort is also very important. We also use many pillows, like this one is the L-shaped pillows that it could help the patient. And also, besides from, we can also use distraction like music, pop-up books for little children, toddlers, clowning. Clowning is using in many hospitals in Taiwan in the pediatric ward, and also sometimes in for the healthcare providers feel laughing and feel very happy when they see the clown in the ward. Now with this laugh will also help them decrease the distress and anxiety. And their favorite toys and games, like the toys here is used in our pediatric ward, is using recycling material to make. And another one is the computer for teenagers, that they can chat and with their other patients and with their friends. So it depends on the person's developmental age. The cognitive behavioral methods is another way that we have music therapy in NCKU hospital, that the music therapist will sing a song, or that make a song, or make a lyrics with the patients that they can pass on to their families for memories. and they can take many pictures, or they read a book and the patient hit the drums with when they are telling stories. And art therapy, imagery, hypnosis often used when we are giving injections or other pain intervention. Abdominal breathing, therapeutic play, psychotherapy. There are many of the cognitive behavioral methods that can manage the pain. Okay. So even though that symptoms have been cured, many of the patients still think the life for many of them is not what you might call normal. It's still not normal. Why? Because they still need emotional support and counseling. What kind of psychological impact will the illness cause for these patients? They may feel living in uncertainty for the unknown future. When will we die? When will the disease come back? When will the pain occur? So they are living in uncertainty and isolation because they admitted to the hospital really frequently. So they have been separated from their peers and other friends or neighbors. Anxiety, even the examination results will cause an anxiety. Anger for their own health, for their family members, for healthcare providers. Sadness and depression, lose confidence and self-esteem when they have like chemotherapy, when they have hair loss, or they have changing in their appearance, and they have fatigue, and they don't have the ability to work. These will cause this lower self-esteem. So in the environments, we can do some modification to help these patients. We can give them music. We can give them, for little children, give them gentle touch, or elderly, and minimize their restraints. So like if you can decrease the use of the restraints of their hands, because sometimes we use restraints because we are afraid that they will pull off their NG tube, but we can use other ways. We're trying to decrease these restraints and minimize the noise. Like in the ICU, there are lots of noise and lights that really disturbing these patients. Or calming and clear speech when they are talking to your patient. Lighting and familiar objects, like putting some photos or some dolls or toys or other things that they're familiar with in the clinical setting will help giving them emotional support. Spiritual care is a very important aspect in palliative care. And now I have a question for everyone. And I encourage everyone to think about this question now. Is it possible to be spiritual without being religious? Maybe you have an answer. And then we have to distinguish the two terms, spiritual and religious. Religious usually implies specific structures, doctrines, narratives, beliefs, practice, and rituals that connect an individual or community in its day-to-day life with ultimate or transcendent concern, such as ultimate meaning, purpose, ground of being, God, creator, or the supernatural. While spirituality is referred to what is to be human, everything. What is to be human? Physically, body, mind, emotions, relationships, roles, social, cultural things. These are all the things that give life meanings and value, and as such is a deeply personal and subjective thing. It also involves the questions about life meaning, about morals and values, and encompass our relationships with others and other people, world around us, and sometimes but not always, the God or a higher power. So in the spiritual care intervention, our ultimate goal is to improve their spiritual well-being. One of the most evident way of spiritual care intervention is the dignity therapy. And here is an example of dignity therapy that I want to introduce to everyone. Is that it uses a interview of 12 questions for the patients and counseling, and letting them think about these questions, such as, tell me a little about your life history. When did you feel most alive? Specific things that you want your family to know about you. The most important roles played in life. Why were they so important? What do you feel most proud of? And then, so here is the photos of the patient. He is Bruno, and he was diagnosed with motor neuron disease in 2016. This is an example I searched from the YouTube. So he joined this, he received this dignity therapy, and they interviewed, asking them these questions, and they having a chance to release their emotions and talk with themselves and their partners and their loved ones. And they record their stories and give them writing down all his story and making them into a book. The book that is so special for him that he feels he is more valuable and meaningful and something he can pass on to his friends and families. So here you can see, here's the book. Okay, so this is the evidence that dignity therapy can improve spiritual well-being and improve their meaning at the end of life.
Okay, then we will go into another topic about the going home from hospital. When we're talking about the palliative care, integrated palliative care, we are talking about we make the family have the more choice for going home, and they will not die. They will less die in ICU. But when the patient wants to go home, and actually they do have the patient and the family members, they do have many needs, because they need to know how to do the personal care at home. Because they are easier to make a bath, going to the toilet, and also for the domestic carers who were cooking, cleaning, and about home adaptations and equipment. So we need to prepare the equipment. They will help that the patient can stay at home and also get a normal life. And also, if the patient still needs some health care, like tracing the wound or with some injection or even the pain control, then how can we provide? Who can provide the home care, health care support? So you have the palliative home care nurse or the community support, and also the emotional care. This is a very tough work to face the dying at home. So food with a companionship and the counseling for psychological. Also, you have the enough economic financials to support the dying at home. And also when especially for the pediatric palliative, we have to think about the siblings. So when we do the care, we also have to concern the siblings' needs. In positive way, when we involve the siblings to care with the patient, and we will see the siblings. Some siblings, they are very well adjusted, and they have a testimony to individual resilience. Also reflective, deliberate family philosophy, and we see the positive because we involve the sibling with the patient care. But we also have to alert the sibling maybe have some behavior in school, like in school they feel very tiredness because I think maybe they could not have a regular sleep. They usually to disturb of the nighttime sleep. and so they will be very hard to concentrate for the school work. And also maybe sibling will have the other trouble behavior, like seek attention by misbehavior, because also they might have the withdrawal child, and in the school is quiet and withdraw, and they will stay in their sadness and worry in their own words. And also in the break times, and they very frequently to ask the searching questions by their peers, because in the break time the peers will ask, will your sister die, or will you get the same? Yeah, so it kind of many different some negative behavior in the school. So we have to make attention about this. So how the sibling may respond? They quiet and want to be by themselves, and they ask if they can go out to pray. And maybe they will get very upset and cry and get angry. So the sibling experience, we try to understand the sibling experience. For they may be worried. They worry about the loss of sibling relationship, and they maybe they will speak and they have some somatic disorders and school difficulties, and they also worry about the future. And guilt, the siblings, sometimes they will think about the very negative feeling toward their brother or sisters, and they feel guilt about that. And they also anger for they got the restrictions on their life, and also maybe the parents expect they have the responsibilities to associate with caring for the brother or sisters. And also other people's reactions to their brother or sister will also feel the anger, and also anxiety, the brother or sister health and progress. Siblings also have some like sadness. They would have the anticipation death of their brother or sisters, feel lonely, feel resentment, feel multiple loss, also frightening the image. And the family, they need the short break and the holidays. Because the process is a long-term life. In the long-term life, we all want to get to the normal. So living as normal life is possible with support to enable this. So for the family members, and for many families, they caring for a patient with complex disability or health needs, and it's very extremely difficult to organize a holiday with appropriate care in place. But we know the holiday or some event is very important for a family life. So sometimes we will help them to organize like a birthday party, some activity they would shift them from the dying, the disease, but we have a normal life and normal happy together. And that would be a very good memory for when the patient or the child passes away, and it would be that is a very, very significant memory as the treasure for them. And for kids, in Taiwan, we have a Make-A-Wish organization, and they are the charities to let the kids make a wish, and also to help the wishes come true, and it's all the get free. So they would let the kids and the child feel so happy before they pass away. And also the family feel that's a very, very variable experience to that the child have can complete their wishes. That like these pictures, the patient they went back to the school, and so that they can we help them to back to school, and then back to school to join the activities, especially for the special days like sport days in the school, and the kids can see all their peers and their friends, and is that the patient feel more normal, and also feel they still have the ability for learning, and they can stay well and stay safe at school. So what family wants when for the community support. So we know if the patient they going home, so they really need the support from the community. So as a policymaker, or as you organize the palliative care system, we need to think about if we want to let the patient and the family make more choice at home to pass away at home, then we need to provide something that the service covers 24 hours a day and the whole years. And the continuity support depends on the individual's family needs. So, and also the ongoing system control issues, like they need that pain control at home, or some symptoms they need to continue. So here is the physician. They can go to home, go to the patient's home and make the assessment and provide some prescription or the treatment. And and another way is very important to provide the respite care, and that the family have some time out for the normal family life. And also the parent support group, we can provide the information and the expert advice or benefit advice, and also maybe provide some small grants to support the family, and the emotional support, practical help. And also we found some research to make more survey to more understand what the patient or the family want at the community, and raise the awareness for the whole people in the public. So in these pictures, I also want to make some comparison between this talk. We're talking about the palliative care in adults and in children, but actually they are all the palliative care, but they have some very different and unique parts. For like for the overall caseload, for the pediatric, actually the caseload is smaller than the adult. So it means in the pediatric palliative, it's also more difficult to get more experience about that. So and not that all the healthcare professionals to accumulate the experience for how to provide a good pediatric palliative care. And in the individual's conditions, the pediatric situation is extremely rare with diagnosis specific to childhood or young adulthood. And the illness part, the pediatrics also is the familiar. There is the family, the all family issues, and the care responsibility. Usually, the adult will care by themselves, but for the child, the parents and sibling also have to provide the care, and also when we care we have to look at the whole family as the unit for the palliative care. And the developmental characteristic, for the adult, they development to close the relationships to others. But for the kids, for the child, they still continues in the developmental stage. So we are, even for the palliative care, we are also very considerations of their physiological, emotional, and cognitive development during all the periods. And in other care issues like the adult were also concerning about the work, the financial and the traveling issues. But for the child, we will think about we will continue to provide. They do have the opportunity to pray, and they also need the continuous the education in back to the normal life. And the decision making and the law, the adults can have their own independent will and the advanced decision. But for that part, the children have relied on the parents to make the decision. But of course, we especially for the young child and the adolescents, the parents also have to respect and to understand the willing about the adolescents.
So from just as Professor Huang said, there are a multidisciplinary need from these patients. So which different professionals are involved to provide care for people with palliative care needs? Like I said, the multidimensional needs, not only for the patients, for the physical symptom management, but also what we have said previously, all of these multidimensional needs, and also the family of these patients, their siblings, and their environments that we have to take care of to provide them better quality of life. We'll need a multidisciplinary team approach. For the universal service, which is the service provided for all people, then these are the people provided for all people but also a foundation for good palliative care, include the health and the social care services available for these patients, like primary care team, social worker, and school teacher, dentist, community-led approaches. In the core palliative care is a majority services required by the people with palliative care needs. These include the family doctors. They can assess the changing health for these patients, prescribe drugs, even though they don't have to go to medical center, they can get their drugs at the community. Community nurse will give injections, change dressings. Rehabilitation team will help them with equipment, make a home safe and comfortable. And okay. And dentists, like home dental care, is also very important because these patients are too weak to go to hospital and they will have a risk of infection, so they will need dentist and at home. And the palliative care charities will give them other benefits that Professor Huang has mentioned. The last one, the top one, is the specialist palliative care. These are for the care that have specialist certificates or training of the healthcare professionals. And these professionals team includes the palliative care consultants, nurses like case manager, coordinator, home care nurse, shared care nurse, social workers, psychologists, OT, PT, pharmacists, dietitian, and also like chaplains provide religious care or spiritual care for the patients, art therapists, music therapists, child life specialists, hospital teacher will help them keep education even though they are in the hospital. So these needs are usually during end of life, and especially during end of life, that they will need a very specialist team to provide their care, to control their very difficult situation.
Okay, here I would add something about, of course, we cannot have so many luxury. We all have the multidisciplinary experts in the same team. But here we provide that, is that as know, in the palliative care, we have so many different dimensions needs. But of course, if you could not have so many experts here, then we will keep in mind to say, actually, we can find some, we think about the patient or the child, they are really need that. And maybe other professor like nurse and like social worker, we will work more then about, we will expand our expert for that. And here I would like to talking about the outcome measure in palliative care. When we're talking about that concept, we also need to know when we have to start to do the next step. So the outcome measure, I think the definition of this outcome is the change in the patient's current and the future health status. And then so we have to know that change. So the measure, we will ask patients to report about their health status and measuring at the subsequent time point to assess any change. So the change will help us to make a decision making for what is we have to do. And the outcomes list include that the change in symptoms, emotional, spiritual, and social concerns and the issue for the families. Even this is very hard for some people with advanced disease. It is very hard to see that. But in the whole process, we need to frequently to measure the outcome and to see where the patient is. And the actually, when we do the outcome measure, they also combine that the clinical assessment, such as that the assessment of the issue of the patient and the family. And that is very useful to do the screening, to screening who is maybe appropriate to using the palliative care. And also those measure or those assessment is a good data and a good things to do the multi-professionals communication, because we can have a standard way, a systemic way to do communication. Also to know how to do the prioritize the care. And like here and in the assessment and the final outcomes for patient and family, that is also very useful to communication, and that every multidisciplinary team members can have the same goal for that, and also they can determine the result. And for that they would be very good for to learn about the individual patient in real time. And also in the clinic, there is a good audit to see that we can, with a systemic review of practice, and help to improve our care of quality. And also they can demonstrate the superior outcomes and to explain the complexity of what palliative care does. And this outcome measure also is a very good research instrument, and they can provide the patient's level data and the evidence. We have the real data to see that, and based on the result, we can assist do a good, more appropriate policies to prepare for the very best payment. And here is, well, I showed one type of the outcome measure instrument. We call that is a palliative outcome scale, and they have a different modules. And also this data is this instrument is the data has come from the staff, the patient, and the care versions. So it's a multi-dimensions data collection, and then so it will be more. And also that is not only include the physical symptom part, also include the emotional, spiritual, and social concerns. And for those instruments, we also have another instrument we call the C-POS. The C-POS is for child and for the pediatric. And in the child item, we include the pain, other symptoms, the cry, and happy, play, relax, socialize, and does question answers, or does the family or significant others spend the quality times? And for the family items, to see the family worry and the shared feelings, does share the information, help and advice, and the family competence to care for the child. And now we integrate the CPOS into our routine care in NCKU hospital. So we train all the staff to know, all the pediatric staff to know how to use the CPOS, and the support the coordinations in each department. So we can using this data to communicate with the within the departments, like the nursing department, the medical departments, and all the palliative department. And also this is a good way to do a continue medication education to all the staff. So now we incorporate the CPOS in our the care. Like now the CPOS in the children palliative outcome skill we put in the computer system, and this is our case manager. Our case manager, and she uses the CPOS. She continues frequently to assess the patient, and also involve the parents, so they all can in the same step level to understand the patient's the child's situation.
And aside for outcome measure, we have situation to tackling taboos, breaking bad news. It's really often in the clinical setting that we have to tell them the truth of the bad news. And here are the first, most frequently we use family meeting. And the family meeting beforehand, we will have a pre-family meeting, which is involved not the patient and the family, but only the multidisciplinary team, that we have to came up with a consensus. What is the person's prognosis? How will this information be shared? How will the team like to see the person's care move forward? And what options for care will we offer, so that we have a better family meeting with the family and patients and having a consensus. During the family meeting, we in the sitting part, we will invite the healthcare, the healthcare providers, like nurse, doctors, the family members, the patients. It will be better if they have patients, and for them to choose what seats they want to sit, and we observe their relationships between them. Second, we introduce the members. Third, we develop a shared meeting agenda. We will have to know what the topic they're interested, they want to discuss first, what information they want to receive, and what they don't want. And the fourth, ask them about their understanding. Before we give information, remember that we have to ask their understanding first. Then fifth, we provide additional information that they maybe have misunderstanding, misconceptions. We also have to educate them about the palliative care concepts. And the sixth, we check their understanding afterward. Seventh, we attend emotional impact. So for the physician for a different multidisciplinary team in the meeting, you can decide who will be the appropriate person to provide emotional care, and who will be appropriate person to provide some information, and so that it will be a teamwork in this meeting. And the eighth, identify the goals for care. This is the most important part, and I will mention it later. The ninth is express commitment. After they having a goals of care, we have to express that we will try our best to reach that goals of care, and what measure we will do, what plans we will do next. To reaching a goals of care, we have better to use open-ended question. And patient and family mindset, well, I want to prolong my life, prolong his or her life as long as possible. I want him to survive and wake up, something like that. So you have to keep asking, what else? What else do you want? Does the person know his prognosis? What are the person's greatest fear about what is to come? What are you most afraid of? What is the person's goal? What are you hoping for? What are the trade-offs that the person is willing to make for the possibility of more time? So what is most important to you? We have to educate and keep communicating, leading them to think about these questions so that we have got a good goals of care. Remember that don't be too brief conversation. We often see healthcare provider moving quickly to urgency and the details of the treatment. We have to be slow and make it clear. We avoid jargon or ambiguous terminology, euphemism, like it won't be long, it is really unclear, or we're not saying being made comfortable. That is sometimes unclear for the family and the patient. We avoid muddled hope. We avoid them to increase their sense of false hope. We don't say something that is untrue or don't have the evidence. We repeatedly reinforce, and we also avoid repeatedly reinforce negative information, because sometimes it was too overwhelming to receive so much negative information. So you probably the family meeting will not discuss all of the topic, that you have to use a second family meeting to discuss the other. The last is avoid holding stigma. So we're often seeing healthcare providers sometimes having stigma or fear, apprehension, that they're afraid of raising the conflict between the professional and the family. So we have to avoid that. That is not helpful for the communication. And do's, we have to offer common language, create a private, quiet, safe communication atmosphere, reassure that the patient was safe to ask any question, and use open questions. And then the next slide, we have to listen for cues that what they want, more or less information. We present facts honestly. We use the word death and dying clearly. We just said death and dying. Don't say other unclear words like not getting very well. So we have to say they have a risk for dying. Then they will be more helpful for them to come up with a consensus and revisit their preferences for communication throughout the treatment, because patient and family may change their preferences and may take a team approach to communication with openness. Okay. Unless as a maintained hope is very important. Even though patient with palliative care, even though they are approaching death, hope is even more important. Hope can be maintained, but the nature of hope will changes. We're not fighting for life, we're fighting for getting a quality of life. So prepare for the worst, hope for the best, and they will have to know at least that they will be well taken care of, even though if their condition deteriorates.
Then we are talking about the providing end-of-life care. And in the providing, the first we were talking about the anticipatory grief. Actually, the grief they express in advance when the loss is perceived as inevitable. So the death of another, when the death of another patient in the pediatric ward, and the mother with the parents would think about, this could have been my child, and will my child be next? And if the spiritual or religious traditions focus on the illness as a punishments, then the guilt will into the anticipatory grief process, so that the parents will say, I feel guilt about her. It felt to her lot should be cursed for the family's bad luck. So we have to deal with that and to understand the anticipatory grief, and also to know how to work with that. And so this picture is that when we recognize the deterioration for patient conditions, then we have to know now the patient is maybe facing to dying, and we have to conduct the palliative care family meetings. And in the family meetings, we have to identify with the patient or the family any wishes for care, for the end of life care. So so you will see we have a different stage. We have different family meeting to set up and to communicate for each other to set up the same goal. And the details of, we were talking about the details of the death, that whether to attempt the CPR or not, and the time, what the time, and who was the will present in that time, and ask the dying patient, the person, where they want to die, is die in the hospital or die at home, and who they want to be present at the time of death, and how and what their cultural, spiritual, or individual needs can be met. And also, if possible, in the hospital, maybe a single room accommodations would be good for them to have that. That's very important timing. And in Taiwanese culture, especially this is for that in pediatric palliative. Actually, we would say that if the black hair should not perceive white hair, it means a child should not die before their parents. But and also the death is considered as bad luck. So so the death is also considered a punishment from that's the evil. And the progress of terminal illness can be harmful to patients. And if we share that, and it may be even the hasten their deaths. So so they prefer to taking an indirect approach. So we were not directed to say the term, but we were we will discuss the patient's illness and progress with family members, and sometimes not direct to the patient. And this is our the culture in Taiwan. And we healthcare professionals, we have to face that is our culture and how to deal with that. And these pictures we are show when the patient passed away. We still see the patient, the disease as a person, and we will provide their privacy, their dignity, and a good, very peaceful environment. So you will see we will clean the body and clean the mouth, and even we do some makeup, and to that looks so peaceful and also looks so the dignity. And also in Taiwan, we need, usually in our culture, we will have the disease to wear the shoes, because they still have a long way to go. They have to walk, so they would prepare a shoes. So we will wear all things. Also we will make a towel, the towel roll to hold the jaw. So the personal care of the body is very important for us to provide after the pass away. And it's not only for the person, it's also for the families. The family members, when they take this work together, and they really think about they support, and they also work with the person, and they respect them. And when the person they go to the mortuary, you will see we will respect all the procedures. So we help them from the ward to go to the elevator, and before and then we have to say goodbye. All healthcare profession we respect. We use a very respectful way to say goodbye. And in the elevator, they also bow to each other and make the whole process is more so peaceful and acceptable. And usually the family members is very, very touching and very memory for this moment. And
okay. Now I'm talking about bereavement, and all of the Professor Huang have mentioned, these intervention will help the bereavement care for the family as well. After the patient die, we will continue our bereavement care. And we have received this a saying that a father of a deceased child, he said, like suddenly falling down, she has already passed away. What else do I ask for? So they are very grieving and very shocked sometimes, and very angry, and many grieving emotions during this period. And we have to aware sometimes grandparents are suffering a dual loss. They mourn the death of their grandchild, and also they grieving for their adult child suffering as well. So these grandparents, we have to address their bereavement, and we have to provide them support. On top of the impact of the death of the patient, the family have faced a series of additional losses. The losses include the supportive community at the hospital, and so many of us, we lose the contact with the patient, with the family after the patient died. So the family will lose the supportive community from the hospital. They move. Sometimes they move to other different area so that they want to forget the deceased loved ones. But they found they losing the place they associate the loved ones, the friends, the neighbors, and their routine. So this is another secondary loss. And the last one is the final difficulties, including the loss of the benefits and the cost of the funeral. And many of them, they not only lose the patient, they lose their job as well, and lose their friends, lose their colleagues. So these are called secondary losses. We have to know that, and we have to understand. And what can we help for grieving family? We open our communication with them. We encourage them to express their feelings and their thoughts of grief. They might need the information about why my child died, why me. So we have to give them information and let them speak, let them say about their thoughts and views and feelings. And remember the whole person who has died. So we encourage them to look at their memory and express their feeling. We don't say you cannot cry, you have to be brave, you cannot say anything about them so that you will forget faster. It's not true. They will still be in the bereavement. So we also encourage them to meet and talk with others who have the same situation, who has been bereaved.
After we're talking about that, during the all lectures, I think you would understand for the palliative care, we are in the multidiscipline. And so the training and the competence for the healthcare, the team members is important, very important. And also we have the consensus for what is palliative care, and the competence to do that will be our focus for the training. Now, so now in NCKU hospital and our teams, we have the joint up approach to education and the training, like the curriculum for all staff and across the specialties and at the different levels. So you will have a level 1, level 2, level 3 training, and to get the different the certificates. And also in NCKU hospital, we almost like a palliative care training center in the world. So the people from the different country also come to here to get the training. And the regular multi-professional team meeting is important because we need to more discussion. And another important meeting is case-based discussion. Now we have every other week we will discuss the case, and when we discuss case, the people from the multidisciplinary profession will work together. And also in another room we have many students or other junior staff. They also will listen. So the the idea and the concept would be more common during this. And the palliative care learning hub or the psychological and because that, so we also have the very good psychological support to each other. All the member teams, they are a very good psychological support to know, because it is tough to do the palliative care, but the support for each other would be the most important part for that us can go down. In here, we'll see this is Professor Zhao Keshi. Professor Zhao Keshi, we call that is a mother of the palliative care in Taiwan. And now the Professor Zhao Keshi actually is a trainer, an expert in the world. I mean, not only in Taiwan. And this book is one of the basic of comfort measure. It means the palliative care, not only the oral therapy. You are not only talk or not. The important part is the comfort measure, the comfort care. So when we start to the palliative care, we start from the comfort care, because people, the person, they need to get the comfort, and comfort care will have the many procedures. So we have this book, and to many many professors, they are working in the palliative team. They know this is our basic competence. Okay, so today we are very happy to can share the experience in Taiwan about the palliative care in adult and child. And I think it is different from the previous you talk, because this time we add more concept and we add more experience about the pediatric parts. Okay, and I will open the time and shift the time back to Diaz for the discussion and the questions.
Thank you very much, Professor Huang, Michu, and also Sabina, for giving such an informative and very comprehensive information related topic. Start from the palliative care concept to the bereavement care, and in the very practical way, giving an example how we to do that. And now I invite students to asking questions directly. If you have any questions, please just open your microphone and then say your name and your major. Is there anyone would like to have a questions?
And I see a questions in chatting room.
Oh yes, Professor, this is one questions. Probably while waiting the others, I would like to read the questions. How is family support for children palliative care? Please provide more example about that.
Does you want to provide your experience about this part?
Yes. First of all, I think if we have a trust relationship, we have better to involve the palliative care earlier with the parents and families. And we have to initiate the discussion of palliative care, so that they will have know that we have the members of a multidisciplinary team that will help them. And the basic is that we have the trust relationship with them. And these multidisciplinary help will provide not only physical comfort for the patients, like pain control is the most important comfort care, also emotional care, emotional support for the patient and the family. We have to have a time for them for emotional counseling and letting them to express their feelings and helping them to solve their problems and know what they want, what their preferences, what their goals of care. And we do our best to achieving them. We have a multidisciplinary team. If they want to go home, we have a team that in a community. If they want to stay in a hospital and die in a hospital, we have the place with privacy, and we're helping them that they can stay with their child, even though they're in the ICU or even though their child is dying. And we're giving them the backup, the support. We're helping them how to plan for the future. The child might still want to go to school, we can help them with we have a team helping them with the go to the school and communicate, coordinate with the school teacher. So we have lots of things to support the family who have a child with palliative care need.
Okay, thank you, Sabina, for your answer. I would like to echoing your answer a little bit about you saying that to integrate more earlier, more better. As from the presentations, we heard that the concern in leading palliative care discussion is like about failure to predict the timing. So probably you can share how early is to integrate the palliative care in, how early as, how soon as, how early we can trying to integrate palliative care, especially in the pediatric palliative care.
Okay. Okay, I will answer first, and Sabrina, maybe you can raise in some other parts. And when we talk, actually in the past experience, when you start to do the palliative care in pediatrics, and it's always the taboo to talking about the death, and especially for the cancer treatment, all parents, because now we know that the cancer patient, that pediatric cancer, now they have a very high curative percent, so the mortality rate is decreased. So when you have got the cancer, it's not mean going to death. It means you can have a very high possibility to get a cure. So that's why the all healthcare team, they want to make the goal is to let the patient cure the kids. But of course, we know we still have to shift this here. So how early we can do actually is that at the beginning we have to work with the physician, and we make I think several years to work with the physician, that the physician should accept the not only his job is not only to provide a treatment, he also can provide the support. And when the physician really feel the treatment may not get a good effective and may not good outcome, we are not to push the parents and the patient to get more intensive treatment. But at that time, when we directed to say, oh, then we provide the palliative care, and usually the parents would very many worry about that term. So maybe we will start from the now the patient or the family maybe need more support, like more support for the symptom control, more support for the psychosocial issues, or more support from the stress. So actually we start to do that, but not really say, oh, that's palliative care. Yeah. And when we start to say, then we can build up the trust to each other, and then to see in the hospital, you are not only receive the aggressive treatment, you also receive the care for comfort, for decrease the symptom and decrease the pain, and psychosocial support, and even to think about to deal with the grieving, the loss issues. Yeah. So how early if we are not, if the concept change, palliative is not going to die. Palliative is part of the treatment, and the treatment can integrate with the disease treatment. Yeah. So I think and we have, but we changed the concept of healthcare professionals, and our team members, we changed the concept, and we also using this concept to work with the family. Yeah. But I think we still, because of pediatric, we don't have many pediatric cases, but we try to step by step. I think after several years, it's improved. And also we also have more people they involved, like Sijun involved in that field. So we have more members and more that we can discuss about that. We can develop the same goal, and we have the consensus to work with family. Sijun want to say something about this?
Yeah. I have seen in the chat room someone asked about what if the parents afraid of being palliative care, and this is also our barrier. Many healthcare like nurses say that the parents or the physicians don't accept the patient receiving specialist palliative care. But what can we nurse do? Before we consult palliative care specialists, we still can do many things. We can provide comfort care and emotional support for the parents. We can give more detailed information if they don't know what's wrong with it, what happened, and if they need a spiritual care, they need some ritual, some religious intervention, we can try our best to provide. We can give support for them. So even though they are not consulting a specialist team, even though they are still receiving curative treatment, it is a parallel intervention that combine the curative treatment and palliative care. And what else problem?
Yeah, the another question is about the sibling preparations that I want to ask about. The Sarini is I want to ask about how to make the sibling relationship doing well between the children with chronic conditions, and another one who is might be feeling grieving losing their brother or sister with the terminally conditions, so they can support each other.
In a healthcare setting, we encourage the siblings to come to visit, and other important family members. We also encourage them to take on this care, even though the patient is in ICU during the family visit. We encourage them to provide care directly to the patient. They have to be more understanding that what's the situation is going on. We have to check their understanding of the prognosis, and we have to train them to really take on the intervention to care for their child, like suction, like something comfort care, so we help them to have a plan for going home, that they have the ability to take care of their child. And the siblings, they need the time with their ill brother and sisters. So they sometimes, for teenagers especially, they're most close to their siblings than their parents and the other healthcare providers. So we have to let them have time to play together, to chat together, and we have close relationships with the siblings. We have to listen to what the siblings concerns, what their fears, and what's their other behavior problem. So we have to coordinate or encourage the parent to coordinate with the school teacher about the siblings' behavior at school. So remind the teachers that these students have a deceased brother or sisters is important as well.
Okay, thank you, Sabina, for your answer. I think I read like interesting questions from Irma Gita. She's saying like how to deliver the spiritual care among children with a terminal illness, because she said that probably it's quite difficult to asking like, do you what's the meaning of life or something like that. So how another way to deliver spiritual care in this population?
Yeah. Okay. And sometimes for really small child, toddlers, a young child, their spiritual well-being is they are feeling happy, feeling loved, feeling meaningful, feeling expected the next day happen. So sometimes some toys play with them. They are expecting your visits is also a spiritual care. They're expecting your company to tell a story, play with them, or making some little thing, create some things that they can give to their parents, that they can show their love. And these are also the spiritual care for little children. And sometimes the psychologist can help with that as well.
Okay, thank you for such an answer. Probably because of time, I would like to have one more questions from the Heldawati. She asking what the biggest obstacle to deliver or establish palliative care in Taiwan, and the second is to provide the educations to a community settings in order them to understand about a palliative care issue.
Okay.
I will answer the second, and the decision answer the first. And in the I think when we start to talking about the palliative care, palliative terms, and actually we in Taiwan, we at the beginning we talking about anning. Anning is like a peaceful for dying, peaceful. And actually we do not only working in the hospital. Actually we working in the many in community, in the social medias. We try to, and I think at the beginning, the Professor Zhao Keshi, and we have a team within Taiwan, the team members from North, from South, and not only the healthcare professionals, we also have many volunteers and the policymakers, and in the community, we let the because I think at the beginning, we think if you are in the hospital, you have to aggressive to treat until you die. So even on the last minutes, we still need to do the CPR and to let everybody know the healthcare professionals already done everything we can do. So we cannot save this person. And then we try to change that first, and to know peaceful dying would be another goal we can do. So we change the law for even we change the law to say that you can sign the DNR if you think the CPR could not just prolong your life, not save your life. Yeah. So something like that, we change that, and then we continue to make the many stories and some informations and so many lectures in the community and the social medias. So you will see year by year, and more people they are accept when we are in our death will be one of your life work. So how to prepare that? And now I think several years ago we passed the patient autonomy law. So the ACP is also now is very common now, and I think the Professor Gao will have some part to talking about that. So to change the concept about the palliative or about the peaceful dying, it should be a long way, but we have to do that from difference. And I also think about another very important thing is in that team, we invite many volunteers, and the volunteer is another very important power to improve themselves and also improve the people in the society. Yeah. So I think that would be even that's a long way, but day by day they will help our health professional. It's more smooth to provide the palliative care and to improve our care quality. Okay, I will shift to Sujin.
Okay, so many people say concerned about the resource, lack of resource, so only specialist palliative care can only provide it for cancer patient or patient who have DNR order. But in Taiwan, we also have, because the health insurance coverage, there are some limitations for palliative care consultation. But as a nurse, I think we can still working on really hard for reaching the patients and families' goals of care, understanding their preference, providing the multidisciplinary care, helping them for going back home, and helping them with their other siblings or community care. This we can do. And even though with the lack of resource, we still have to work on it. but we can firstly think about what else we can do under this barriers and limitations.
Oh, another part, I think another part is the palliative team is also very strong to do the fundraising. They do a lot of fundraising, but of course the volunteer is very aggressive to do the fundraising. So then we can sometimes if you cannot really get the resources from the government, but we can based on the we can have the fundraising and to get more budget to do the things we want to do. Okay.
Okay, thank you, Professor Huang, and also Sijun for the nice and very clear answer. Okay, because of time, I think before we move to the next sessions, I would like to give a short summary as the conclusions for our first sessions. So the increased needs of palliative care, especially in the low middle income country, and by considering trajectories of dying of terminal illness, palliative care expected to be maintain patients' conditions and also their quality of life, and most valuable if it integrated as early as possible. By doing so, not only patients, the palliative care may also benefit for the family and also carer. And there is a new approach, a model to explain the better way of palliative care, not only among a healthcare provider, but also patient and family, so-called BOTI model. And also pain is the most essential symptoms to be maintained in the patients during the palliative care. And the last is like a multidisciplinary and specialist team might be needed to provide palliative care, and the palliative pediatric care have a more challenge in terms of special circumstances of individual conditions, care responsibility, developmental characteristic, and also the issue of autonomy in making decisions. So we would like to thank Professor Huang and also Sabina one more time to deliver such an informative information. So thank you very much, Professor Huang and Sijun.
And just before we shift to the next one, should we take a picture?
Oh yeah, yes, Professor. Okay.
Everybody here, and including Professor Gao is here.
Okay.
Yeah, so how about everybody back to the screen and or open your mic your screen.
Your screen, yeah. So everybody, can you open the screen? We are going to take a picture. Probably the committee will help to take a pictures. Miss Irma or Miss Camille?
Yeah.
Yes. Do you?
We want to take a picture together.
Yes.
Okay. Wait. Okay. 1, 2, 3. Correct. The moment. Again. Okay, the next. 1, 2, 3. Okay. Again, because let's have 5.
Because I have a 5 slide,
yeah,
Professor,
5
probably
slide.
we need to take like a 5 time.
Oh,
so, okay.
1, 2, 3 again. Yeah, the slide 3. 1, 2, 3. Okay. And then slide 4. 1, 2, 3. Okay. And then the last slide. 1, 2, 3. Okay. Done. Thank you, Professor.
Okay. Thank you, Professor Huang and Sijun. Now we will have like a 10 minutes break in order to move to the next session. So please come back on time on 11:10. Professor Kao, do you would like to practice to share the screen first?
Okay, let me. Can you see my screen now?
Yes, but it's not full screen, Professor.
Okay, how about this one? Is that okay?
Not yet. Yes.
Okay.
Okay. I think the screen is okay. Professor voice is also quite
Yes.
clear.
My voice clear?
Yeah, yes, Professor.
Okay. All right. So let me how to sharing the screen. So okay, stop sharing the screen. Okay.
Check. Oh, all right, ladies and gentlemen, now we are going to start our second section lecture with the topic of palliative care management at the hospital and community in Taiwan. Next slide, please. Okay, so our second speaker today is Professor Qin Gao. She is an associate professor in the Department of Nursing, College of Medicine, National Tsinghua University, and she is also a director of Taiwan Academy of Clinical Research Nurses. She is the member of the Honor Society of Nursing, Sigma Theta Tau International, and she graduated from University of Melbourne, Australia. Her major are cancer care, clinical trial, palliative care, patient autonomy, adult health nursing. She also had a lot of long list publications and research grants. And the most recent publications was related to palliative care published at the Australian Journal of Primary Health and also Indian Journal of Palliative Care. So we are very lucky to have her as an expert in this topic. Without any further ado, please join me in welcoming our second speaker, Professor Qin Gao. So time is yours.
Thank you, Deyas, for your kind introduction. Good afternoon, everyone. Let me share my screen. Okay, so is my screen working now? Can everyone see my screen now?
Yes.
Okay,
Yes.
so let me, okay. So thank you very much for Deyas introduction, and thank you very much for Camille to invite us to have a speech for the student in Indonesia. So today's my topic is hospice palliative care management at the hospital and community in Taiwan. So before I start, to move to the next. Okay, before I start, I would like to have, just like Deyas mentioned, my currently is the associate professor at NCKU and also the director of Taiwan Academy of Clinical Research Nurse. And my research interests including cancer care, informed consent, decision making, palliative care, and patient autonomy. So this is the outline for my topic today. So at the beginning, I will briefly introduce the Hospice Palliative Care team in NCKUH, National Cheng Kung University Hospital. Then I will individually introduce Hospice Inpatient Care, Hospice Home Care, and Hospice Shared Care. Then finally, we'll link to the Advanced Care Planning. Okay. So let's start a brief introduction of palliative care. We all know actually the birthplace of palliative care is in the United Kingdom, and the founder is Cicely Saunders. She is also, she is not only a nurse, but also a doctor and a social worker. And I believe in the previous section, Professor Huang also mentioned, this is the Professor Zhao Keshi. She is our palliative care mother, and she lived a palliative care work in Taiwan. And currently she is also our advisor in our palliative care team. Okay, so let me briefly introduce the history of Hospice Palliative Care team in NCKUH. Actually, from 1996, we start the hospice work from hospice home care. Then after 2 years, we start run the hospice inpatient care. At that moment, we only offer 12 beds for inpatient care. Then in 2005, we start because the government policy, so the NCKUH start run the hospice shared care. And until 2012, our hospice inpatient bed increased to 20. And just 2 years before, we have the Center of Hospice Palliative Care. Okay, so let me talk about the care goal of Hospice Palliative Care in NCKUH. Actually, we work to help patients to achieve good death and death peacefully. So the good death means, patient could have physical, psychosocial, and spiritual well-being. For example, if they have some physical symptoms such as pain or dyspnea, this symptom could be controlled by medication or the nursing intervention. Moreover, we also offer good support for families. It's also called Bereavement Care. And finally, we hope not only family, but also team members could live well after, from now to future. So it's part of the goal of our hospice palliative care. And actually, the philosophy of hospice palliative care in Taiwan is also, we provide 5 whole care is also be promoted by Professor Zhao Keshi, including whole person care, whole family care, whole process care, whole team care, and whole community care. So the whole person care means actually people need patient. We need to provide patient physical, psychosocial, and spiritual care. So this kinds of over patient holistic care. And for family care means we care about family's emotions. And after patient is died, we continue provide bereavement care to their family. So it's kinds of whole process care. And in addition, in order to achieve whole person care, whole family care, and for process care, we need to have multidisciplinary members to participate in this care, in our care team. So we also, so it's called a whole team care. And the fifth one, the last one is the whole community care, because we want actually patient not just stay in the hospital. We want the final goal, they could go home and have home death. So it's also, so that also demonstrate the importance of the community. So the community care, so we also call it as the whole community care. And this is the hospice palliative care service in NCKUH. So you could see actually we have 3 parts. As I mentioned before, the first part is inpatient care, and the second part is shared care, and the third part is home care. However, this third part, they work very closely, they support each other. So it will provide patients with a high quality of palliative care. So here, let me just briefly introduce the staffing of hospice palliative care service in our hospital. So in total, we have 41 physicians in provide hospice palliative care service, and we have 47 nurses, including 1 supervisor, and 24 nurses in inpatient care, including 1 head nurse, and 16 nurses for home care, and 5 nurses for shared care, and 1 hospice palliative care specialist. And we also, like I said before, we also have multidisciplinary team member, including 1 pharmacist, 1 social worker, 1 nutritionist, and 1 spiritual care worker, and 1 music therapist in our team. And also expect health professional. The volunteers is also very important to provide good care. So so we have 37 volunteers to support us to provide palliative care in our hospital. Okay, so here is the nursing, only focused on nursing staffing of palliative care service in our hospital. There you could see actually for the working years, because in my previous stage slide, I already mentioned the manpower. So let's move to the working years. So here you could see, except the inpatient care, the nurse working experience, average nursing experience is nearly 3 years. But for home care and shared care, their average working years is more than 10 years. So we could see how experienced for this nurse, they provide palliative care. And almost nearly 80% of nurses in our hospice palliative care team, they all receive 80 hours hospice palliative care training. And nearly 50% of nurses have the hospice nurse certificate, and 1/3 of them have the hospice nursing preceptor certificate. Okay. So this is the hospice palliative care nurse training program. We separate as the 5 stages. So in the first stage is the new staff training. So when the new nurse come to the hospice palliative care ward, they need to complete the new nurse training and learn about how to provide the comfort care and how to assess and management the terminal symptoms. Then, so after they finish the first stage, they could move to the second stage. And the second stage is cross-training. So for the cross-training, they will be cross-training in oncology and hematology ward, because the majority of patients receive palliative care are cancer patients. So we want them to learn the knowledge and skills of cancer care. Then, after they finish the second stage training, the third stage training is hospice inpatient training. So at that time, they need to learn the core ability of palliative care, such as difficult symptoms management, clinical ethical dilemma, or decision-making competence. And also they need to complete the basic and advanced hospice nursing training. And they will need to get the certification of palliative care nurse from Taiwan Association Hospice Palliative Care Nurse. Then after they complete the third stage, they could move to the fourth stage. And the fourth stage is hospice home care training. As we know, not like in the hospital, when you do the patient care in their home, you need to have the individual critical thinking. So in the hospital home care training, the nurse need to have the problem solving and communication skill with patient and family, and also multidisciplinary teams, because sometimes nurse need to visit patients home by themselves. But sometimes they need to visit patients with other health professionals, such as physician or social worker, and to deal with patient's concern or family concern. So at that time, the communication ability is really important. And we also hope the nurse at this stage need to have the nurse hospice palliative nursing preceptor training. So they could also get the certification of hospice palliative nursing preceptor from IAPN and start contact with advanced care planning training. And the last stage is shared care training. So here you could see actually the shared care, the level of shared care is the highest one. Because the shared care, we need to sometimes, after this slide, in the shared care section, I will talk about when the original care team will consult shared care. So because you need to individually deal with a lot of issues raised by the original care unit. So the nurse work in the shared care team, they need to have the critical thinking ability and also need to deal with other communication issues or symptom issue with multidiscipline. So they need to also have the communication skills with multidiscipline. And they need to have the teaching ability to of hospice palliative care, and also need to get a certification as a preceptor from TAHNP PN. Okay. So let me talk about, let me move to the hospice inpatient care. All right, so this is the hospice ward in NCKUH. We call it as the Sanya ward. So the Sanya, actually, this word is from Sanskrit word. It means, it's a concept of the Buddhist. That means human beings could achieve liberation from the cycle of existence. Thereby, they could gain full enlightenment. So outside the Sanya wall, it was surrounded by Sanya forest. And actually this Sanya forest is formed by the Sanya trees. So each leaf representing a donator contribute the Sanya wall. So it's kind of public acknowledgement, the importance of palliative care, and also the seed for spreading love. So this is actually, this is the picture the Sanya ward look like. So we do our best to establish the home-like environment. For example, during the Christmas season, we want to provide a patient and family to enjoy the Christmas. So we will decorate our ward to let them enjoy the Christmas. And also, in this ward, we also have the sunlight room. So this room could allow patients and their family to have some rest or enjoy the sunlight or discuss something they would like to discuss. And we also have the chair room for family meeting or bereavement care. Okay. And this is the our service provided by Sanya ward, the inpatient service. So the inpatient service, including with the function of education, demonstration, and consultation. And also, actually, the inpatient service, the Sanya ward, is kind of a support unit for home care and shared care for care of the difficult patient. We also call it hospice ICU. So here you could see our health professional and patient family to have some enjoy their great time. And here you could see our nurse guide the family and the children to help have a bed bath for the patient. And this is the food care for our nurse and volunteer. They provide the comfort care. So actually this is our inpatient service have a lot of functions. And outside our the Sangya ward is the gallery. So here we have a regular expectations for for this one is the children's book to talking about what will they face if their family death. And this is some painting for made by our patient. And this is some message for patient and their family member. So this is kinds of this artwork are made. This expression can make could assist patient, fulfill patient's wish, and the most important thing is that we can conduct live review with patient and guide patient and their family to share their feeling, their thoughts through this preparation process. For example, through the painting process or through leaving the message process. Okay, and this is the mourning room. So when after patient passed away, their family could have their ceremony according to their religions, such as Buddhist or Christian or Muslim. So in this room, it is also very important part of bereavement care. So these are the equipment of used in comfort care. As Professor Huang mentioned, actually comfort care is very important in the palliative care. So in the Sangya ward, we have a lot of different type of pillow to assist us change patient's position. And we also have this is the fan to reduce patient's dyspnea. And also have the air purifier. And also this is the ultrasound inhalators to assist patient to exhale their sputum. And this is the hair washing machine. So because sometimes when patients stay in hospital too long, and especially for terminal patient, it's really hard for them to have a bed bath and wash their hair. So this is the hair wash machine, and this is the ultrasound bath machine. So we could assist patients to do their comfort care here. And this is the ultrasound. This is the infrared radiation. We normally use this when we do the foot care and foot massage. Okay, so here you could see our nurse and volunteer and family are working, assist patient to receive ultrasound bathing. And also here is the care to provide by nurse to do the hair washer and foot massage. Not only provide the comfort care, but we also very focused on psychosocial and spiritual care. So here you could see in the Christmas season, we will have some activity for patient and family. They are Christians because actually Christmas is very important for Christian people. And also we have the Buddhists to provide patient with the their religion are Buddhist, will provide their spiritual care. And also the bereavement care, you could see here, our nurse assist, this is our nurse, will assist family say goodbye to their patients or sharing their thanks to the patients. And also, this you could see our music therapist assist patients and their children to take care of the patient before they expire, and also our nurse to deal, because as Professor Huang and Shijun's topic mentioned, children and children is very important part of palliative care. How to care their emotional, how to deal with their bereavement care is very important. So you could see we also will invite children, patients, children to have some games to share their feelings or their emotional, their thoughts, to talking about how's their feeling when their family is nearly to death. And not only psychosocial care, but bereavement care is very important. So here you could see after patient pass away, we continue provide families bereavement care. Actually, we have twice a year for the bereavement group meeting or activity twice a year. So family member or they will make at this activity and share their feeling and their thoughts, and it's also kinds of bereavement care. Okay, so the first section is regarding to inpatient, hospice inpatient care. Let me talk about the hospice home care. And the essence of hospice home care is continue the hospice palliative care and to achieve patient-centered care and assisting patient and family with hospice care at home. And so they also allow terminal patients to enjoy the time with their family, and they could also receive the medical treatment at home. And these kinds of care could also reduce the hospital resource and reduce family burden. They don't need to stay in the hospital. Okay, so let me talk about the source of hospice home care patient in our hospital, including inpatient, referral from inpatients, and also referral from clinic. Sometimes we have in the individual contact by their family or referred by other hospitals. So here, actually, this is the map of Taiwan, and this is Tainan here, the pink one. So you could see the star mark is the NCKU. So the service area of our hospice home care is under this blue black light. We offer our hospice home care nearly half of Tainan, and also achieve, this is Kaohsiung. Actually, Kaohsiung is the north of Taiwan. So we also provide our service in some areas of Kaohsiung. So the service time of hospice home care is actually Monday to Sunday, and is 24 hours, 7 days phone call consultation. Sometimes we still need to provide night service if necessary. Okay, so what will we do in home care? Except providing the physical care or comfort care, we sometimes we will also have the family meeting at home. So the physician will just bring their laptop and some equipment to connect hospital's internet. Then they could discuss patient's condition with their family member, or discuss with their family or patient directly. Okay, so these are papers, these are some photos to demonstrate. Actually, we could also, when we provide the home care, hospice home care, we could also have family meeting. And this is the symptom management. So for here, you could see actually when patients have a lot of ascites, they will feel abdominal distance. So actually at this time, at home care service, the physician could provide the abdominal synthesis to drainage the ascites and help patients reduce their fall distance. Okay, so this is also the drainage of ascites. And also, if emergent, if need, the nurse will assist patient to have the IV lock to provide some IV fluid or pain medication to relieve their symptoms. Okay, and this is the comfort care. Some pictures shows the comfort care, like the nurse will provide the oral care, mouth care for patient, and will teach family to have a bed bath at home or hair wash at home. And as you could see from the picture, actually they need to use the equipment at home. So just some simple and easy tool to access at home. And also check patient's vital signs and provide some massage care at home. And remember in the previous slide, I mentioned sometimes we will provide, we still need to provide night service if need. So this is the picture, the emergency visit at night. So normally average this kinds of emergency visit at night is around 5 to 6 times per each month. So normally the patient, the nurse will get a call if the patient experience like tumor bleeding or severe pain or in a dying process or severe dyspnea or fever or urine retention. Our home care nurse need to visit this patient if emergency. And also, if, like I say, sometimes if patient in the dying process, the nurse and physician will need to visit them. And at that time, we will also provide a dying support, not only for family, but also for children. So this is the hospice home care service in our hospital. So here you could see actually our case is around 500 to 600 each year. And this for 2020, we only calculate half year. So the number is around 300. And the visit by nurse is more than, is increased every year. So, so in 2019, the visit by nurse each year is over 7,000 times. And in the half year of 2012, the visit is over 4,000. So we expect the visit times in 2020 is over 9,000 times. And this actually, sorry. And visit by physicians is, here you could see, actually in 2017 year is around nearly 200. But after that, it dramatic increased. Okay, dramatic increase to 1,000 and over 1,000 because this is according to our hospital policy, because we want to encourage good deaths. Patients have good deaths at home with health professional. So our hospital provide physicians with 400 NTD dollars for each visit. So here you could see after we the hospital policy changed, the physicians' visit times also increased. And here is some data for home deaths for patients receive hospice home care. So here we could see the percentage of home deaths is gradually increased. In 2020, it's around 80% patients receive hospice home care and they have home deaths. Because that, like we mentioned in the previous, in Professor Huang and Shijun, we don't want patient, we want patient die at home with the dignity. So during their dying process, if they receive hospice home care, we want they stay at home, not just sometimes, because sometimes when family feel panic during the dying process, they normally will send patient to the emergency to the hospital. And the first station, the first stop is the emergency room. However, as we know, actually during the emergency room is very noisy. It's not a very appropriate environment to provide provide palliative care. So if possible, we want to provide the care at home and let patient death at home. Then I will move to the third part is the hospice shared care. Okay, so this is the service of hospice shared care in our hospital. Actually, the shared care is provide terminal patient and family. They are not in our hospice ward, Sanya ward, but they have physical, psychosocial, and spiritual care needs. At that time, the original care unit will consult hospice shared care, and the team member will visit patient at the original care unit. So during this visit and consultation, it could improve the care, the quality of hospice care at the original care unit. As I mentioned before, actually, our hospice palliative care also have the function of education and demonstration. So during this consultation, the shared care team will demonstrate how to provide comfort care, how to provide symptom care or bereavement care at the original care unit. So it will also improve the health professional at the original care units to improve their hospice palliative care quality. And we also could assist with the training of national hospice specialists, including physician and nurse. They have the internship to participate in this shared care team. Okay, so if you remember, I mentioned previously, our hospice shared care start in 2006. So this is the brief survey I conducted in 2007 to understand the palliative care consultation. This consultation is referred to hospice shared care in terminal cancer patient, among terminal cancer patients. So here we could find there are top 3 needs when consulting the shared care. The first one is the psychological care and spiritual care. And the third one is truth telling. I believe today we're talking about a lot of psychological care and physical care. So, so in the next section, I will follow about the truth telling and why truth telling important in palliative care. Here, I would like to share some research finding with you regarding does the awareness of terminal illness influence cancer patients' psycho-spiritual state and their DNR signing. It's also a survey in Taiwan. So here we could see, we separate the patient into unaware layer terminal prognosis group. And the other group is patient, they are aware of their prognosis group. So here we could find actually a patient, they know their disease progress is not so good, it's nearly to death. Their uncertainty level will significantly lower than patient, they don't know their disease prognosis. And also their anxiety level will, for patient, they know their disease condition, their anxiety level will significantly lower than the awareness group. And here we could see for the before they refer to the hospice shared care, here for the awareness group, the DNR sign percentage is also significantly higher than patient they are not aware their disease prognosis. Also, here we could see if patient they know their disease prognosis, they tend to have higher percentage sign the DNR by themselves. However, for the awareness group, you could see the nearly almost 95% DNR are signed by family because patient they don't understand their disease prognosis. Also, the day from sign DNR to death is for the awareness group is significantly longer than the unawareness group. So it's almost twice, doubles, more than 70 days in the awareness group. So this shows us actually if we assist patients with to deal with truth telling, they could have more time to conduct, to understand their condition and to conduct the death preparation. So not just sign before one day before their death. Okay, so here is the DNR consent before and after hospice, refer hospice shared care team. So here you could see after refer to hospice shared care, the percentage of DNR signing is generally increased, have significant increase. And also, and for here, for the DNR options, for the awareness group, they tend to sign the DNR without vasopressor and intubation. Okay, so previous section, we're talking about the importance of truth telling. Then for this paper, we were talking about the effect of hospice-based palliative care team. Actually, this is we call the hospice shared care, the effect of hospice shared care. And we find out actually the hospice shared care could significantly improve the symptom management and spiritual well-being because as you could, if you still remember, one of the consultation needs is for the hospice shared care is truth telling. So if patient to deal with the truth telling, the issue of truth telling could be deal well, like it could also improve their spiritual well-being. They could reduce their uncertainty and anxiety. And so finally, it turned out actually the hospice shared care is a good care model to provide palliative care in Taiwan. Okay, so this is not in the ICU. This is the picture in the ICU. So actually, this is our shared care nurse. She teach the nurse in the ICU nurse and family how to deal with babies' physical care, and to this is teach them how teach family and nurse how to conduct a bed bath. And also, this is the picture. Our shared care nurse assists the patient. This is a patient in ICU. They assist the patient to fulfill patient's wish. This patient, they want to participate her daughter's wedding. So our shared care nurse invite the ICU team and also our social worker to have a wedding in the ICU. So like this kinds of activity fulfill patient's wish before patient pass away. And it's also the shared care nurse will guide the nurse in ICU in the original care unit and family to conduct the postmortem care. Is really important part of a bereavement care for family member, and also maintain patients' dignity when they dead. So this is the so let me talk about the reasons for case closed receiving hospital shared care. These are the reasons. The first one is the patient's problem already be solved. Like their pain management or dyspnea already be management well, and for some patient they could refer to the hospice ward or refer to hospice home care, or after their symptom management and patient getting well, they could discharge, or sometimes they could discharge due to terminal or death, or refer to chronic care institutions. So here, I already is the main part of our hospice palliative care team's work. And I would also like to share the key to successful hospice palliative care in our hospital is, of course, as I mentioned before, we combine inpatient care, home care, and shared care. We make them work very closely, and they have the mutual support. And actually, our hospice palliative care also have the function of education, demonstration, and consultation in hospital. So each team member could spread the hospice palliative care seat into different departments. And also, in our team, we have twice a month case discussion to discuss difficult patients with original care team. And we also have a regular executive meeting to discuss the difficulty or communication issue faced by the hospice palliative care team. So this is some pictures we show about our team member have some teaching section to our nurse in the hospital. And this is the case discussion. Okay, so the last one, I will talking about the advanced care planning. Okay, before I talk about the advanced care planning, I would like to introduce our good death and patient autonomy legislation and amendment in Taiwan first. So actually in Taiwan in 2000 years, we passed the Hospice Palliative Care Act. This is the first act in Asia and dedicates terminal patients have right to receive palliative care to achieve good death and refuse life-sustaining device. However, according to this act, the terminal stage means the prognosis is fetal with the nearly future. It means patient is nearly to death. And at that time, the act did not include withdraw life-sustaining device. They only mention patient have right to refuse. However, if you already received the life-sustaining treatment, you cannot withdraw it. So 2 years later, we do our first amendment. In this amendment, we allowed patients to withdraw life-sustaining device for terminal patients if they have predetermined document to show their willingness. But actually, most terminal patients receive life-sustaining device are conscious unclear. So their family is unable to withdraw the device on behalf of patient because at that time there are some concern from our legislature. They were worried if a family could, on behalf of patient, they could kill patient, maybe consider their property or their money. So in our first amendment, it's still very difficult to conduct. After 10 years later, we do the second amendment. At that time, we allowed terminal patient could withdraw life-sustaining device if all family members agree to withdraw. And this need to be also, this decision need to be approved by an ethical committee in the hospital. But do you think it is practical? Because, for example, if one of the patient's family is in the United States, they need to take the flight and come back to Taiwan. And after they provide, all family members provide a written document. This document need to submit to the ethical committee and to get the approval. And as we know, the approval period take a long time, almost 2 months. So it's actually really severe for patients. So in 2013, we do the third amendment. We allow patients to withdraw life-sustaining device if one of the family agreed. Okay, so remember our previous slide table shows here. Okay, actually, if patient, one of the family member provide a DNR, then they could withdraw the life-sustaining treatment, right? However, here we could see actually from our previous survey, almost the majority number signing the DNR are family patients. So where is the role of the patient? Therefore, therefore, in 2016, we passed the Patient Right to Autonomy Act. And this is the first act in Asia dedicate patients' autonomy right, refusing patient life-sustaining treatment and artificial nutrition hydration under 5 clinical conditions with their advanced decision. And after this act be announced 3 years in 2019, in Taiwan, we start to implement the Patient Right to Autonomy Act. So it's kind of brief history introduction about the Patient Autonomy Act. So the purpose of Patient Right to Autonomy Act, including respect patient autonomy in healthcare, safeguard patients' right to a good death, and promote a harmonious physician-patient relationship. And through this act, we could solve a lot of problems we meet in the current clinical situation, including legal problems physicians will face, like sometimes patient would like to withdraw the life-sustaining treatment, but their family do not disagree. So after, even though patients have the DNR consent, but after they lost their conscience, their family will change the DNR consents in order to make patient receive the life-sustaining treatment. And some legal problem health institution will facing. And also the most important thing is the legal problem patient will face, because we want to respect patient's autonomy. No one could change their decision. Okay, so this is the SOP for Patient Autonomy, Patient Right to Autonomy Act. Here, the first one, we need to have a person with full disposing capacity. So this is need to be an adult and with mental clear. And then advanced care planning in the hospital. I will introduce this part. We also call it ACP. So during the ACP process, the health professional will discuss the 5 clinical conditions with patient, and also discuss whether they will receive or refuse the life-sustaining treatment or artificial nutrition hydration. And after that, they could sign their advanced decision. We call it AD. Sorry. And with witness and seal, and will also registered in the IC card. So here are the 5 clinical conditions, including the first one is the terminal ill, the second one is the irreversible coma, and the third one is permanent vegetative state. 4 is severe dementia, and the 5th is unbearable, incurable conditions. So when the patient meet these 5 clinical conditions and they sign the AD, the health professional team could follow patient's AD to provide the relevant care. So let's talk about advanced care planning, ACP. Normally we could conduct the ACP in the medical institutions. So the team member, including medical team, we need to have 1 physician and 1 nurse or social worker, and the declarant is the patient, adult people with mental clear themselves, and also have the 1 and 2nd degree of affinity, and the hair care agent if necessary. So during this process, we will fully talking about the people's willingness and what happened when they meet the 5 clinical conditions and what the decision they would like to make, and we will also explain to patient and their family what is the life-sustaining treatment or what is the hydration nutrition treatment, because sometimes during the critical situation, it's really hard for patient and family to imagine what is the imputation. So during this consultation process, it's not so rushed and the time is enough. So we want to sit and discuss well to explain what is the CPR or what is the life-sustaining treatment. Okay, so as we know, after I mentioned before, after patient that meet these 5 conditions, they could have, if they already experience ACP and have their AD, they could health professional team could conduct their AD, right? But these 5 clinical conditions need to be assessed by 2 physicians with the specialty, and also have 2 consultations with palliative care team to determine, okay, the patient's situation currently already meet these 5 conditions. So the AD is that if it in this document, it clearly mentioned whether the patient will receive or refuse the life-sustaining treatment or refuse artificial nutrition hydration under these 5 conditions I just mentioned before. And this kinds of document and this kinds of ACP process is also demonstrate the respect patient autonomy in healthcare, and also safeguard patients' right to achieve good death and promote a harmonious physician-patient relationship. So here, the Patient Autonomy Act approach problem from 4 aspects, including patient, family, medical team, and resource. So for patient, they could maintain patient's dignity and autonomy in healthcare. And for family, we will invite family to participate in the ACP process to understand and respect patient's will. And also for medical team, we will follow the principle of beneficence and to protect by law. Otherwise, like I mentioned before, sometimes when family would like to change patient's DNR wishes after patient lost their conscience, sometimes the health professional will just follow family's wishes, because if not follow, the family member will assume the health professional. And also it will allow medical resource to be used efficiently. Okay, so however, because as you know, actually this act just started 2 years, maybe 1.5 years already. So we still have a lot of issue or challenge we need to face. For example, the cost of SCP is quite expensive, because for the each SCP consultation, it takes 2,000 to 3,000 NTD dollars for each patient. So, and the time limitation for ACP, because normally the ACP consultation only 1 hour or 1.5 hours. Sometimes the time is not enough for patient and their family to understand the real situation in the future. And also during this consultation process, a lot of issue may need to be dealt first, like communication issue. We like to deal with patient and their family first. Then they could move to the next step to talking about the ACP. So these are a lot of challenge with that need to deal with. Okay, so finally, I would like to quote a popular saying from Obama. We have to acknowledge the process we met, but understand why we still have a long way to go, why things are better but still not good enough. So it means for our hospice palliative care, we still have a long way to go, but we focus on patient and family-centered care and aim to provide high quality of palliative care. Okay, so today my sharing speech will finish here. Thank you very much for your participation. I'm not sure whether everyone have question would like to ask.
Okay, thank you, Professor Cao, for delivering very comprehensive information related to hospice care in NCKU hospital. So for the students, I believe you already pay attention to the lecture and then are ready for question and answer sessions. So I will encourage you to ask questions directly. So if anyone have a questions, please just raise your hand and then turn on the microphone. Does anyone have a questions? Okay, while waiting the students' questions, Professor Cao, may I discuss with Professor related to the presentations that you deliver saying that Taiwan finally have an act about the patient's right autonomy to refusing life-sustaining treatment. And I would like to ask about the phenomena before and after this act have been how to say established, because at your presentations you're saying that the previously the sign of DNR is most conducted by family members. So how about when this act is have passed, is there any differences about that phenomena?
Okay, thank you very much for they asked questions. Actually, one of our we already have some survey data. For until now, the most of people they participant the ACP and sign the AD is the healthy people actually. For some part they may have some chronic disease, but actually their physical function is very generally well. This is because actually if you are a cancer patient, you may regularly visit hospital or clinic to receive the treatment. So this kinds of consultation appointment may be too burden for the cancer patient or for terminal patient. So for terminal patient or case or the patient they under our they were covered by our hospice palliative care aid, they could go through the hospice palliative care pathway. And for the healthy patient, if we also do the survey, for this patient they may have some important care experience according to their past experience. They part of their family will get a cancer, so or have some critical illness, and they experience how they receive life-sustaining treatment or artificial nutrition treatment. So they want to decide their death by themselves, their way to death by themselves. So they will attend the ACP. So actually these two types are kinds of, the people are still different for these two parts.
Okay, Professor, thank you for your answer. I see that students from NCKU have a question, so I would like to call Alfian. You may raise your questions.
Thank you, Mrs. Dea, for giving me a chance to have a question to Professor Ko. I'm Alfian, a master's student of NCKU. I'm curious, Professor, about truth telling that you mentioned before. Actually, when I study palliative care in NCKU before, the Professor Lai also mentions about do not resuscitations that still high in a palliative care patient in NCKU. But I curious about the truth telling that you mentioned before. Is there any ethical considerations, ethical challenge, or ethical issue that we as a nurse should consider when we want to conduct truth telling to the patients about their conditions or their prognosis? Thank you, Professor.
So let me clarify your question. Thank you for offering your question. Do you want to understand what the ethical dilemma the
Yes.
nurse face regarding truth telling, right?
Yes, Professor.
Okay, so actually the common situation is normally the family member are worried if patient they know their disease prognosis, they will lose the hope to survive, or sometimes they will choose to suicide. So that's why I conduct, as part of my work, I conduct a survey to support actually if the patient they don't understand their disease condition, they will have higher level of uncertainty, and also have higher level of anxious. So if we could have truth telling, if assist patient to get their truth telling, even though of course our result also support when patient know their poor disease poor prognosis, they will become more depression, but their emotional situation will come back maybe after 2 weeks or one month. But this time, at least their uncertainty and anxiety level is not so high, and it also provides time for health professional and family to and patient to have more time to do the death preparation. But in the real situation is a lot of family members don't want we approach this topic.
Yes,
so really
yes, Professor. Yes, I mean, is that issue, Professor? Sometimes the patient's family don't want the health worker deliver the information about patient prognosis or patient's disease conditions. But the other hand, we want patients will really clearly understand about their conditions. So this is, I think, the issue, that dilemma, and the challenge that we faced recently, right?
Yeah. So if the team has a lot of experience, they could not always. You could imagine if you are a patient, when your physical function deteriorate, you may have some thought regarding to your you were guessing maybe I'm not getting well, or well I nearly to death. So we will first, of course, we need to approach to family to let family understand actually patient already they may have some guessing, or they have some thought, and let patients family know the importance of truth telling. So for this part to approach, we will and also need to this health professional need to have a good communication skills. So to deal with this complicated issue, and also need to understand what is the purpose behind families this kinds of situation, because sometimes it's because family they don't know how to deal with the truth telling, or they are afraid. They are some fears behind this intention. So we need to deal with these fears or patients feeling first. Then for most of the case, the discussion or the case, truth telling could conduct well if we could deal with families' issues.
Okay, Professor, thank you so much.
Okay, and the next questions from student Dia Rima. Can you say your questions to Professor Kao directly? Dia?
Yes.
Okay.
I want to ask how to start the hospital that has never helped before. And are there any obstacles faced in starting this hospice care gitu, Professor?
Thank you for Dia's question. May I just repeat your question? You want to understand how to start the hospice palliative care,
Yes.
inpatient care, if this hospital without experience.
Yeah. Yes. Yes.
Okay.
Yes, Professor.
Yes, so I think the academic association is really important because like in Taiwan, we have hospital associates of hospice palliative care nurse. So actually this academic and professional association will help us to provide some important component. And also we could also learn from some, like as I remember the Surabaya, right? Is the palliative care birthplace in Indonesia, right? So I believe in Indonesia, you must have a lot of experts in this area. So the hospital could also invite this expert to guide the hospital how to build up the hospice palliative care service in your hospital. And I'm not sure whether Professor Huang would like to address that, or because they are ask if the hospital they haven't provided palliative care before, how to help the hospital to provide palliative care.
Thank you.
And I would maybe like in Taiwan at the beginning when we try to promote the hospice care, and we start from the hospital. So, but of course at the beginning we start from hospital. We have many dimensions to do it. That the first, of course, the concept of the palliative, the leader, and also the staff, they should have that, the first thing. And the second thing, the training for the staff, because training for staff, that would be very important. For if we have a hospice care, then the staff training would be another major issue. And the third is the environment, because for the hospice ward is not equal, not similar to the general ward. In the hospice ward, we need to have a good environment, because you know the care is include the psychosocial and family care and spiritual care. So usually we will the space is always very luxury, but we need some key spaces is needed. Especially for one single room, for spiritual care, and also for when the patient pass away, and we will move the patient to that space, and that family can stay with the dying patient together. That would be another very important thing for that. So another part is in the hospital, we need to prepare some the structure of the words, and also to make the important values to see what kind of space we have to deal with. And also because we think the staff training is very important. So in the world, we also will find one place we can have a meeting room, and in the meeting room, the education, sub-education, and the team members' communication and meeting or the case discussion would be held for there. Yeah. And I think, of course, there will be the stage. And I have to mention that for the whole process, one group is very important. We will call that volunteer. The volunteer, build up a volunteer group would be another very important push for do that, because the volunteers come from the community, and actually they do have some resources from community. Include that the resources or fundraising, or share the ideas to the community, and also to provide our volunteer. You know, if I want to be a volunteer in the hospice world, I need to go through the all education and the training. And during the education and training, we got a consensus for what is a better palliative care or hospice. Yeah. So that's our experience for that. But finally, the most important thing is we need to have a good leader, and the leader really want to do this, and also have a good value for this, and to see the value is good for the patient care. Then everything will be also very easy to do it. But we need time.
Okay, thank you, Professor Huang, and also Professor Kao for the explanations. And then we move to next questions. Zoom, you would like to say your questions?
Yes, thank you, Professor, for your speech. I would like to ask a question about the bereavement care for the family. I want to ask, normally, how long we will provide the bereavement care for the family? Maybe 1 year or 2 years after a patient passed away, and how to deal with the problem if we lose the connection with the family? That's my question, Professor.
Okay, thank you very much for Xiaorong's questions. So actually, before patient pass away, we already start to conduct to prepare the bereavement care, like such as the post-mortem care. We invite family member to clean patient's body, to assist them to look very clear with dignity in their the last before their funeral. So it's kind of the start of the bereavement care. And after patient pass away, normally we will have phone contact to family member. But we also respect family members' willingness, because for some family member, if they don't want to be bothered by our health professionals, we will just respect, but we will keep our greetings, let the family member know actually if they have any issues or they have any emotional disturbance, they could contact us directly. And we also have regular, like I mentioned, we have twice a year's regular bereavement activity. We will invite, but it's not the compulsory. We will invite a family member to join. So it depends on family member. So if they lose, we will just keep follow up. And during the dying process, we will assess whether the family member belong to high risk group or not. If they are belong to high risk group, our social worker or our nurse will contact the family member after patient pass away more frequently. Yes.
Okay, thank you so much, Professor.
Okay, thank you, Professor Kao. Following Zoom questions, I have another questions from the chat platform. Would like to ask about the palliative care according to the two presentations that have delivered. It like have a close relationship with the psychology, both of patients and also family. So probably could you explain with an example how the role of nurses in reducing family and patients problems so that they do not cause another disease for the patients and family? This question is from Yusuf.
So Yusuf's question is would like to understand how to deal with psychological issues, right? Sometimes we deal with like the not so close relationship between family and patient. However, it doesn't mean these kinds of far relation is unclose relationship is not. It doesn't mean I don't care my parents. So we will spend a lot of time with the family and patient separately to understand their concerns, and hopefully we would like to pray a bridge to like the buffer, to play as a buffer to deliver patients' wishes and or families' wishes, to let them know their concerns through our assistance, then to deal with their issue. But it takes time actually. Yes.
Okay, thank you, Professor. Because of time, I would like to ask one more questions. The last one is from the Hannah Febrianti. How do we provide palliative care services during this COVID-19 pandemic? Because like a hospice, home care, is there any how to say, challenge to deliver that services?
Okay, so you mean the hospice, home care, or the inpatient care? So because for the inpatient care, we are if the patient are in the hospital, even no matter they are in the hospice ward or in the ICU or in the general, if they really need, we could allow family to visit patient. And even though we encourage they use the videos, but if the some emergency situation, if like a patient is in a dying process, and because in Taiwanese culture, we want before patient pass away, all family member will stay beside the patient. So our hospital is allow family member have the special consideration to visit patient in a hospital. And for regarding the hospice home care, that's the challenge one for the health professional, because they need to well prepare themselves. But I think luckily in Thailand, the pandemic is not so serious. So, but it's still very challenging because you need to well prepare yourself and your equipment.
Okay, thank you, Professor Kao. So, ladies and gentlemen, we finally come to the end part of this event. So, I would like to give like a short summary from what the speakers have presented. That the first is the care goal of hospice palliative care is to help patients achieve a good death and then deliver achieve physical, psychological, and spiritual well-being. And the philosophy of hospice is provide a holistic care, treat patients and family as a whole, involve whole process and also whole team. And then the hospice home care services provide several care, include like a symptom care, comfort care, and also emergency visits. And for the advanced care planning is a part of patient's right autonomy to reviewing life-sustaining treatment, which might be initiated if the patients meet like a 5 clinical conditions. And advanced care planning respect patient's autonomy and also provide a good death for the patient. So I would like to thank again to Professor Kao for deliver her topic. And now on behalf of the committee, I would like to thank you again to the all speakers like Professor Huang, Sejun, and also Professor Kao for the informations and very interesting presentations to the participants. And also I would like to thank you to the participant for the active participations. You give many questions. So hopefully the lecture will be beneficial for everybody, and allow me to over the control to the Master of Ceremony. So Mr. Kamil, time is yours.
Okay, thank you, Mrs. Dea. And again, I would like to express my gratitude to our speaker today, Professor Huang, and also Professor Kao, and Association for all the materials. I believe that there are many we can take home. Yeah, we can learn from this event. And students as well, thank you for your participations. The questions are interesting and also enlightening. And also I would like to remind you, don't forget to submit your assignment tomorrow. Yeah, the deadline is tomorrow, so be sure to make based on your specialty. I mean, if you are in community, so try to explore more from your perspective from the community nursing. And before I close this event, I would like to invite Mrs. Irma to help us in documenting. So we would like to take picture together. So please open your camera.
Okay, can all of us to open the camera so we start to take a picture together. Okay, let's start. Slide 1. 1, 2, 3, cheese. Okay, and then the next slide. Please open the camera. Okay, 1, 2, 3. Okay, next slide. Okay, 1, 2, 3. And then the last slide. One, two, three. Okay, done.
Okay. Now, before we finish, let's say Hamdalah.
Alhamdulillahirrabbilalamin.
Alhamdulillahirrahmanirrahim. Alhamdulillahirrahmanirrahim.
With this, I close the event. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you for all the speakers.
Thank you, Professor.
Thank you, Sijun.